we're going to have Dr. Usama Hamza from Egypt talk to us about his efforts to get the whole continent of Africa together in this global project. Dr. Hamza is a professor of cardiac surgery in Egypt, and he's been a very, very good friend of mine for many, many years. And I was very happy to have him speak to us about this today and find the amazing things that he's going to be able to do for us in the whole world, his contribution for the world. So he's the Interact lead for all of Africa, and he's in Mansoura University in Mansoura, Egypt. Thank you very much. And then following that, we'll have the same sort of presentation to see how they're tackling the same problem in China. It's not on the program, but we were asked, and I think we can spend a few minutes to see how they do it as well. So Dr. Hamza, they're always nice to see you. Very nice to see you today. I hope it's warm there in Toronto today. It's minus 22 with a wind chill of about minus 30. So I'm sure it's a little bit warmer there in Egypt.
Yeah, how are you doing? Hi, everybody. Well, in Mansoura now it's about 5 or 6 degrees, which is chilling here and unusual, but we can manage. I had the opportunity to be with you in Toronto, and I am proud of being there. I am a professor of cardiothoracic surgery, Mansoura University. I am the head of the department. And I have a hard task to bring the whole continent together, Africa continent. It's challenging. To start with, let's have an overview over Africa. It is the world's second largest and most populous continent after Asia, of course. About 54 countries, 1.4 or 1.5 now population. Unfortunately, few African countries have the resources to provide cardiac surgery care in their population. Available data described only 213 heart centers in only half of the countries in Africa. Only 22 cardiac centers are in the sub-Saharan for the number of centers, let's compare to North America, it's 1 cardiac center per 120,000 population. In Africa, it's around 1 center per 30 million population. 860 cardiac procedures are done per million people in North America and Europe, only 60 per 100 million people in Africa. The number of cardiac surgeons in Africa is almost 1/10 that in the Western world. For sure, cardiac surgery requires relatively sophisticated diagnostic and surgical techniques and high-level infrastructure operated by personnel and advanced training and expertise. The manpower and the infrastructure required is largely unavailable in African continent. Apart from South Africa and Egypt, and to a lesser part in North Africa countries, Morocco, Algeria, and Tunisia, the fact remains that the entire continent lacks the appropriate cardiovascular infrastructure. Talking about the challenges, there is a long list of challenges facing developing cardiac centers. We are not talking about database and the interact, but to have centers doing cardiac surgery. There is low quality equipment and maintenance, poor financial sustainability, problems with growth and expansion due to regions' isolated location, poor health and literacy of the patients. This is an overview of different parts of Africa, North, east, south, and west, poverty is more than 50%. However, there is some hope. Recently, several African countries have already started promising cardiac surgery programs that will benefit the local patients and the economies. Of course, in Africa, there is international volunteer teams helping the people in Africa strongly help to provide long-term educational and commitment and support until the centers reach their full independence. Interact in Africa, cardiac tumors being rare, markedly affected by the poor cardiovascular infrastructure in many African nations. Several aspects, for example, late surgical intervention, lack of reliable medical records, lack of research facilities, lack of internet and database. Our approach to reach that poor continent, I have to say that, is I started to identify the distinguished cardiac centers in the continent, mainly South Africa, around Egypt, and North African centers. By the way, we have in Egypt about 10 cardiac centers out of total about 25 centers, but about 10 potential centers that have their database and doing at least 600 to 1,000 cases per year. I started to contact the national and regional cardiology and the cardiac surgery societies. We started to stress on starting a reliable medical records in each center, in each potential center we are contacting. I am full of hope that the Interact will find its way in Africa and make a great change in the concept of data collection and registry in the developing continent. I'm sorry to say that, but it's a difficult task in Africa. But hopefully we will find our way, and even to start with a few nations, a few countries, a few centers, and start to build up from that. Thank you very much.
Dear Professor Kusmano and colleagues, nice to meet everyone. It's a great honor that Professor Kusmano chose to cooperate with Fuwai Hospital and invited Dr. Jiangping Song to be the leader of the Interact research in China. As the Chinese New Year is coming, I wish you all a happy New Year's. Next, I will introduce how to develop interactive research in China and discuss with everyone. Fuwai Hospital was founded in 1646, which belongs to the Chinese Academy of Medical Science. It's a national AAA first-class hospital specializing in cardiovascular disease. It's also the National Center for Cardiovascular Disease and the National Clinical Research Center for Cardiovascular Disease. It's well known internationally for treatment of all kinds of complex, difficult, and severe cardiovascular disease. And has become one of the world's biggest cardiovascular center, as well as a national center for clinical health care, medical research, disease prevention, and education. At present, Fuwai Hospital has established 3 sub-centers, including Central China Fuwai Hospital, Shenzhen Fuwai Hospital, and Yunnan Fuwai Hospital, forming a nationwide cardiovascular disease prevention and treatment network, forming the core basis of domestic leading and international first-class innovative cardiovascular medicine prevention, scientific research, transformation, and personal training. In 2020, since 26, the annual operation volume of Y hospital has reached about 14,000. In 2020, the number of operations decreased slightly due to the impact of the epidemic of COVID-19, but also research the 9,660 is the largest cardiovascular disease diagnosis and treatment center in China. So volume of operation at 3 sub-centers is also increasing. In 2020, surgeons at Fuwai Yunnan Cardiovascular Hospital performed 1698 cardiovascular surgeons, and 3,963 cases of cardiovascular surgeons was completed at Fuwai Central China Hospital, and 1171 cases was performed at Fuwai Shenzhen Hospital. These 3 central sub-centers are located across the north and the south of China, which lays the foundation for intellectual research in China. The cardiac tumor surgeon accounts for about 0.52% of all operations, about 100 per year. Myxoma is still the main type of cardiac tumor, followed by sarcoma. Taking cardiac sarcoma as an example, introduce the treatment experience of Y hospital. Sarcomas are the main cardiac tumors, of which angiosarcoma is common and mostly invaded the right heart and blood vessel. And other types of sarcomas, such as pheochromocytomas, are mostly invade the left heart. Surgeons significantly improve the prognosis of patients with cardiac malignancy, especially for those who have undergone orthotopic heart transplantation. In order to better carry out intellectual research in China, in addition to the leadership of Y hospital, we also need to unite with large heart centers in other provinces, such as Xijin Yuan, Xijin Hospital, Wuhan Union Hospital, Chengdu West China Hospital, Beijing Anzhen Hospital, and Shanghai Xinhua Hospital, Guangdong General Hospital. We will establish cooperate network to promote the diagnosis and the treatment of cardiac tumors and improve the overall treatment level of heart tumors in China. On the basis, we will establish a national database of patients with the cardiac tumor, follow up the long-term prognosis of the patients, promote the knowledge related to cardiac tumors, and improve the public's understanding of cardiac tumor. On the basis of establishing cardiac tumor operation, on the basis of establishing cardiac tumor cooperation centers, giving play to the expertise of each hospital, develop a patient-centered, multidisciplinary team diagnosis and treatment, including cardiac surgeon team, cooperative circulation team, imaging team, pathology team, and intensive care team. Exclude clinical research. We will also perform some basic research, such as single-cell RNA sequencing for the sarcoma, to identify the cell complex in the tumors. Next, I will introduce 2 special cases next. A 21-year-old present with a 1-year history intermittent hypertension, palpitation, and axial sweating. Plasma and urinary catecholamine and metapherin levels was significantly elevated, suggest phenochromosarcoma. But the abdominal CT showed normal adrenal glands bilaterally. The whole body somatostatin receptor CRgraphy and CT imaging identified abdominal focal uptake adjacent to the right heart. Under the cardiac MRI was performed and showed an overall well-defined mass in the right anteroventricular groove. It's the 3.5 plus 3.8 plus 4.8 centimeters in size. The mass comprises the right atrium, the tricuspid annulus, and the right ventricular inflow tract. For the first pass perfusion documented a rapid uptake of the contrast shortly after its administration, indicated abundant vascularity. The multimodality imaging plays an important role in the diagnosis of cardiac paraganglioma. Cardiac coronarography demonstrated many small branches from the right coronary arteries feeding the cardiac mass. After the adequate pre-operation preparation, the mass was successfully resected. Histological and examination confirmed the diagnosis of cardiac paraganglioma. Analysis indicate that surgical resection is a primary and effective treatment modality for the cardiac paraganglioma patient. Next case is 9 years old, was admitted to the hospital because of expressional dyspnea, intermittent fever, fatigue, and inappetence for 3 months. But she didn't have chills on night sweat and had not lost weight. Chest X-ray showed the posterior and anterior view showed the cardio-thoracic ratio was increased. A high density was not behind heart. The left lateral view showed an enlarged left atrium and abnormal high density at the region of lower left pulmonary artery. And the ECG showed a sinus rhythm, but indicate left atrium enlargement with biphase P wave with more than 14 milliseconds. And the ECG, the echo showed a large mass with a clear boundary in the left atrial chamber. It produced into the left ventricular cavity through the mitral annulus during the diastole. This mass obstruct military inflow, and there was a small amount of cardiac infusion. The atypical full chamber view showed that a mass in the left atrium that was connected with the mass in the dilated left lower pulmonary vein. The MRI showed the mass was smooth and lobulated, but with one part located in the left atrium and connected to another part in the left lung via the left lower pulmonary vein. After the surgery, we found the large part of the tumor with a size of 3.5 plus 2.5 was in the left atrium, and the smaller part with a size of 1 plus 1 plus 0.5 centimeter was in the lung. And the tumor section was homogeneously solid, grayish white and hard. After the operation, patient was in a good condition. UCG examination at 1 year follow-up was normal. During the years, with a summary, the surgical experience in Hawaii hospital. For about heart tumors, especially malignancies, complete surgical resection is preferred. But heart transplantation is also a bad choice for malignant tumors that can't be resected or the heart structure cannot be reconstructed. For ventricular intramural tumors, it's still difficult to operate. For benign tumors without symptoms and without affect the cardiac function, observation and follow-up will be suggested. If the tumor is malignant, heart transplantation is recommended due to the poor survival after excision. Chemotherapy is not recommended for heart tumors except lymphoma. Radiotherapy can be considered, but the effect is not so good. For metastatic tumors, even if the primary tumor can't be resected, the removal of cardiac tumors may benefit for patient if the patient can tolerate. That's all. Thanks, everyone.
All right, well, that's great. Thank you very much for two lectures from two different places that are huge populations. So Egypt has Africa has 1.4 billion people. China has 1.5 billion people. And they both have the same issue as we have here and everybody in the world has, is how to get a person into the system when there are issues with respect to resources, but also issues with respect to getting people identified early. And this is part of the mandate of the Interact project, is to find those areas of excellence, and Fuai Hospital is definitely an area of expertise around the world. It's also to have the global interaction of specialists who are all interested in the same topic. And it's also an opportunity for us around the world to help each other with respect to problems that they're having in their various parts of the world. Are there any questions for either one of these two individuals, how they're going about doing it? You may think that Dr. Usama in Hamza in Egypt has a more difficult problem than the Fuai group in China, but in effect, they're essentially the same. Now Africa has much more of a problem with money, but sometimes when a person has a project like this, it stimulates people to develop their own institutions more than they would otherwise do so. The Interact database form, and it's not completely finalized yet, you'll find those people that are going to join it are going to be very easy to fill out. It's not going to take very long. We've kept the database to a very, very short form, but it'll be very easy to implement. You won't have to have a lot of money to do it. You'll have to have a lot of money to subsequently treat them, but the concept of finding areas of excellence and silos of experience will be beneficial to everybody, not just for those individuals who have cardiac tumors. So I think both areas are really good, and it gives an idea of what we're trying to do with the Interact. Dr. Lestussi's online. She's the cardiologist in charge of Europe. Now she has some help. She's not the only person in Europe. We have a surgeon out of Germany, an oncologist out of the United Kingdom. He's on the talk today, and we have Dr. Bridget Kerwin, who's going to coordinate the whole world for us. Does anybody have any comments or questions about what they saw with these two lectures? I think it's interesting, the comments from the Fuai Hospital about the chemotherapy and the intracardiac tumors. So even a very, 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 very highly specialized area can have interaction with other people, and we can have interaction around the world about this, about trying to answer those very questions. An institution that does 16,000 cardiac procedures per year, 16,000 cardiac procedures per year, they've seen very few cardiac tumors. And I think it's quite interesting. And I don't think it's because the cardiac tumors are not out there. I think it's because in the preparatory stages to the referral to the cardiac surgical service, there may be some problems with getting the people forward. I said in my introductory slide, what does the physician do when he or she sees a patient with a cardiac tumor? Right now, the Fuai Hospital people are the surgeons. What do the surgeons do when they see a person with a cardiac tumor? And you've seen the recommendations by the Fuai group there. They may not be the same around the world. And that's what we want to try to figure out. What's the best treatment for these people? I'm not saying it's right or wrong. I'm just saying it needs to have investigation. But what we're talking about is the physician who has a patient who comes, where do they turn? And this is an important problem. And China has just as much of a problem, I think, in Africa, of getting a person through that level of patient going to doctor, going to a specialist, going to surgeon, going to operation. Is not necessarily the fact that there's lack of funds, although that is obviously a gigantic issue, but it's a lack of knowing where to send these people. And that's the concept of the Interact project. Does anybody have any questions?
If I may, can I make a comment?
Yes.
I think that you are right. I think that what is important is to raise the awareness about the cardiac tumors. Many cardiac tumors are undiagnosed, misdiagnosed maybe, and left without any treatment because they are thought to be a dreadful disease. That is actually true if you don't cure it, but if you try to cure, some possibility there is. So I think that the big problem is to raise the awareness of the cardiologists and to recognize the tumors when they see the patients and to send them on time in the proper hospital to be diagnosed and sent to the surgeon. Also to avoid the many misdiagnoses of cardiac myxoma instead of what is a sarcoma, actually. And so I think that the Interact would be useful also for this goal, to achieve this goal. So to raise attention about this problem. And I will show you our experience. And I think that in our experience, we see more and more tumor patients, cardiac tumors, because since we started to cope with them, and first casually, and then when people know that we are treating cardiac tumors, they ask our suggestions. And so this a global net that is helpful for the patients.
You know, the awareness is an extremely important thing. That's one of the reasons I wanted to start the Toronto Cardiac Tumor Conference. It's a conference, and that's why I've kept it free for people to attend and watch. And that's why I've insisted that previous lectures be on the website, so that if a person in another part of the world sees a neuroendocrine tumor, we had a whole year on neuroendocrine tumors, they can go onto the website and learn about it. And patients are calling me or emailing me regarding this problem. And it's an awareness issue that's an extremely important issue. So awareness about cardiac tumors is one thing, but for instance, in Africa, where they have a huge areas of underservice, it's a very important issue to get going. And even just the association with a center such as Dr. Hamza Center, an area of expertise, will be beneficial to a cardiac surgical center in other parts of Africa. And in China, to be able to be associated with a university as a hospital as prestigious as the Fuai Hospital will advance cardiac services in all of China. And so these sort of interactions, these sort of unifications of countries and continents and essentially the world will benefit everybody. Right now, as everybody knows, obviously, we're in a worldwide pandemic. And I think if each individual country were trying to fight COVID by themselves, it'd be a totally different story than the whole world coming together. Even just the reporting of, I can go online and see my friends in Italy because I'm Italian origin, to see how COVID's affecting my, my comrades in Italy and in India, when you hear terrible things happening in India and all the different parts of the world. Just the knowledge that you can go one place and see how your friends are doing around the world, I think it's an important thing. Sub-Saharan Africa is a big challenge. I've just starting to work with Dominique Verboot. He's a fellow in our research fellow in our university, and he has a gigantic interest in third world or global, not third world, global efforts in surgery. And this is a part of that global effort in surgery. This is really a global effort in medicine to try to get this together. But he and I are going to try to work together to try to bring people in sub-Saharan Africa together, the cardiac surgical services. And Dr. Hamza, through his efforts, will do a great amount of service to all the citizens of Africa by taking this on and forming relationships with different people. As Dr. Kerwin said, Bridget Kerwin said this morning, Bridget Ann Kerwin said this morning, it's okay to start with a smaller group, and once we get going with this project, to get bigger and bigger and bigger and bigger. But I've thrown the gauntlet out to people, and they have a difficult situation ahead of them. Same thing is happening in South America, and the same thing is going to happen in the U.S. and U.S. and Canada. And if you think it's hard to get in Africa, imagine the different hospitals in the U.S. and Canada who want to keep on to their own data and are so scared to let the person be identified because of this or because of that. So every place has its own challenges, and every place that is going to do this is going to have different strategies to handle those challenges. And I thought it would be good today to show a little bit about what people are doing to handle those challenges. So unless I don't see any comments on the lecture, I enjoyed both of those lectures very, very much, and look forward to the interaction with all of us together on a global scale. Maybe in a couple of years, we'll have a whole session of the Toronto Cardiac Tumor Conference together, talking about the challenges we had and how we overcame them. It'll help us to help each other, but it'll also help people who have other ideas to get those underway as well.